Hopefully everybody can see these slides. This is the information for CMEs that's always provided and how to receive those credits. I have nothing to disclose regarding this presentation. We're going to talk today about stages of change and the spirit of MI. So what I'm hoping to cover are really some of the core concepts related to what's called the trans-theoretical model for change, or the stages of change, so that you can understand what those specific stages are and how to utilize them as a theoretical concept to assess and treat patients. Also, we're going to talk a little bit about motivational interviewing, how it sort of evolved as a way of talking with patients. And so you can have some highlights about what it is and begin to think, is this an intervention that would be useful for you, and would you consider going on for additional training in this area? And then be able to walk away sort of understanding what are some of those key principles of MI that could be applied sort of across settings, specifically the spirit of MI. So regardless of whether you're using some of the specific techniques, by adopting the spirit of MI, even that could be effective for helping to work with individuals with substance use disorder. So let's start with the stages of change. Why is it important as providers that work with this population that we understand this model? Well, I think that it's first and foremost important to understand that this is an evidence-based model that is helpful for identifying where a person is at and what they need to benefit from treatment. So we know that treatment isn't one size fits all. And it's really helpful to have a tool to be able to clearly identify where a patient is and then match our interventions to that. It's also important, even though we're going to talk about these two things together, and it's often talked about together, that the stages of change model is not part of MI. It is something that absolutely can very effectively be utilized with MI. Because it is a good model for assessing patients and figuring out what intervention they need. But it is not necessarily part of MI itself. So let's talk about what these stages are. Now, these are set up to help us sort of think about like an upward spiral, that as patients move through their recovery plan or their recovery goals, they will come to understand sort of what they need and where they're at different points in time. And so for folks that are sort of coming into treatment brand new, or they're not necessarily quite aware of what they would need to change, they would be entering the spiral at the beginning in pre-contemplation. And then they work through some of these stages, not always in a linear direction, but they work through them eventually to get to maintenance, which would be after I've completed some of my treatment goals. Then I would end up in maintenance, which is where I've learned new behaviors, I've changed some of those old behaviors, and now it's just about maintaining that change. Now, one thing you might notice in terms of this cycle is that relapse is part of this pattern. And that's a helpful thing to think about and conceptually, rather than trying to think about relapse or really slips as something that we don't want to talk to patients about. It's very helpful to educate them that, you know, this is something that is part of recovery. And those are opportunities in which you can really learn, where did my skills fall short, or what got in the way, or what was the significant trigger that made me vulnerable in that moment, and how can I get back to either action or back into my maintenance plan, rather than thinking about relapse as something that should absolutely be avoided at all costs, understanding that it is really part of a natural change process. And that's true for any kind of behaviors that we try to change. If you think about it, anyone who's ever adopted a plan to change their diet or to add exercise to their weekly routine, anytime we move towards any sort of change, the likelihood that we will revert back to old patterns is pretty high. And so just understanding conceptually that that is part of these steps that people work through as they move towards change. So how do we begin to utilize this model to determine where patients fit? Let's identify what they are. The first step is pre-contemplation, and that's really for folks that are either really new to treatment, treatment naive, they're coming in, or they're just at a point in their life where they're not considering change any point in the foreseeable future. Contemplation are for those that recognize this is a problem, they're considering change in the foreseeable future, but they're not quite ready to move on it. Preparation is when they're recognizing, okay, there's some changes that I need to make, and I'm actually going to start to develop some plans in the immediate future to start to put them into action. Action is where we see meaningful change begin to happen. So action is not in the planning, it is change is occurring today. So, or in the recent past, happened yesterday. And then maintenance is the phase that happens after action, which is where change has been established and I am doing certain behaviors to maintain that change into the foreseeable future. So how do we begin to think about, once we've identified where a patient is at, and there are some good assessment measures that can be used to do this. In fact, several of the, when we talk about the screening and assessment lecture, we go through some. And there's one that was developed by our CASA Institute here in the state of New Mexico called the Socrates, which is an instrument, it's public domain. You could utilize that in your clinics to assess patients, and it will tell you which stage of change they're in. So once we've identified, okay, somebody's in pre-contemplation, what we want to focus on is just developing that alliance, building a relationship with them, maybe doing things like a decisional balance. So talking about sort of the pros and cons about their current behavior and beginning to add in a few components of MI, but not really utilizing fully MI, because if they're in pre-contemplation, the likelihood that they don't have enough ambivalence, so that means that they are not, they don't have enough of them that wants to change, to really have MI be as effective as it should be. So pre-contemplation, what we're trying to do is build that alliance, keep them engaged in treatment, and have them start to think about, okay, what is your use doing for you? And what is your use maybe not doing for you? So starting to introduce some of that ambivalence in preparation for the next stage. So when they're in contemplation, that's where we really want to be utilizing the MI techniques, because that's where it's going to be most effective. That's where they're recognizing this is a problem, I do need to change, but they're not quite sure how to move forward. They might lack confidence in their ability to move forward, and they have a lot of that ambivalence. Part of them wants to change, part of them isn't quite sure that they want to change, and that's when MI is really most effective. Now, once we've done a good job in contemplation and we move into preparation, that's where they start to plan out how and what they're going to change. MI is not necessarily going to be utilized here because this is where we could do a lot more solution focused, or we're actually just sitting down with them and helping them to problem solve and think through specifically the steps that they're going to take. So they've already gotten over that hump, they're ready to do it, they want to do it. Now it's just about setting up the plan. And then action, this is where we're going to utilize relapse prevention strategies, because what we're focusing on is giving them the skills and helping them to build those moments of success so that they really have a lot of confidence and self-efficacy in their ability to enact change. So doing concrete goal setting and utilizing some of the high-risk situation planning, trigger identification, urge management. All of those things are going to be effective in the action stage. And then once they've moved into maintenance, it's about just continuing to practice the relapse prevention strategies that are going to help maintain and avoid the kinds of risks that will set them up for relapse. So digging into that in a little more detail, in the pre-contemplation stage, a person who's here is really not yet recognizing that there's a problem, or they're recognizing that this is a problem, but they're definitely not anywhere where they want to do something about it. So our goals really are to just start to gently bring awareness of that problem so that it can surface for them and they can start to really think about, yes, it's helping me in this area, but in these areas it's really not helping me. But our number one goal is to keep them engaged. So to make sure that what we are doing is listening to their concerns, reflecting back their concerns, and particularly the emotions that we hear, the distress that they're experiencing, the grief that they're experiencing, the frustrations that they're experiencing, just reflecting that back to them in a strategic way so that we're starting to really highlight that this is a problem. We want to elicit information about them, about past experiences when they've maybe tried to change, what worked, what didn't work. What are their strengths and what is their attitude or perspective on change? So remembering that a lot of what gets in the way is not actually a lack of motivation, it's a lack of confidence in their ability to be successful. And so looking for what is this person's strengths and how can I highlight those, capitalize on those, and have them begin to see them as resources that they can use as they move into contemplation. And we really always want to be communicating non-judgment, empathy, that we accept them for where they're at, because they're used to engaging with medical providers or really any kind of helpful resource and being stigmatized or judged for their use behavior. And so if we're the one person in their life that can accept them for where they're at, that can go a really long way at engaging and building that rapport. Once they've moved into contemplation, this is where they're willing to think about making that change. They're actually entertaining, okay, I'm ready to do something about this. So the goals that we want to adopt is keeping them talking about it, not emphasizing or de-emphasizing any of the status quo. So why they would continue to use, we don't want to highlight that and reflect that. We want to really start to highlight what are their reasons and their values for making that change. Why do they want to do something different? What do they imagine they would get out of it? What are they looking forward to? We want to boost their awareness that there are multiple options, that there isn't just one way to achieve their goals, and that we can problem solve or experiment or try different things and support them through that process. But that there are multiple options that they can look at to begin to make changes, particularly for those that are highly avoidant, have a lot of other comorbid diagnoses or psychosocial barriers to engaging in positive behaviors or health behaviors, thinking about how can we sort of start on the low end so that they have those experiences of success. So what is the small bit? Can they go from using 2 grams a day to 1.75? Can we have them, instead of injecting 9 times, are they willing to drop to 8, right? So starting to approximate the behavior that we want to see. We also want to reflect and increase the perceived benefit of that change. Why are they doing this? What is it that's truly important to them? Because it's not about capitalizing on the shame or the guilt that they feel about their use behavior. It's capitalizing on the parts of them that want to be a healthy, productive person, that wants to be there for their kids, that wants to be there for their family, the things that are truly important to them, and highlighting those perceived benefits. Some of the things that we can do in that area is to develop discrepancy. So reflecting the part of them that is kind of stuck and why that might be, and then really reflecting the part of them that wants it to be different and why. Highlighting those values and reflecting what their intention is and giving them a lot of positive reinforcement for that intention. Because sometimes the desire is all they are bringing to the table, but that can be something we can really work with. So even though they might not have a history of moving in the direction of change, the fact that they're willing to come and talk to you about it is a really positive thing. And so we want to always be highlighting that. Another tactic that we can use is addressing any potential discord. So looking at when you start to see that show up, you want to shift away from arguing or persuading or coercing into just affirming and accepting this is where they are. And one quick thing that's easy to do is think about the language that you're using when you're engaging with patients. If you find yourself saying, yes, but have you considered this? Or I hear you, but, and then that but is in there, you might be engaged in some kind of arguing. So think about the language that you're using and try to adjust it to yes and that small change can make a really big difference in how we engage with folks that are in the contemplation phase. So rather than having the part of them that doesn't necessarily want to change or is afraid to change and reinforce that by using yes and providing whatever rationale or information or encouragement that we're going to follow up with, they can hear that because they're not hearing it as an argument. They're hearing it as still supporting you, I'm still hearing you and reflecting what you're saying, and I'm offering this additional information. So I can hold both of these discordant things in my two hands together rather than it be either or. So that's just one small thing that you can adjust right away. The other thing that we want to be focused on in contemplation is supporting self-efficacy. So that's where we really want to be digging into asking what past successes do they have? And it doesn't even have to be about their use behavior. It could be any past successes that you could capitalize on. Really trying to affirm, remain optimistic and hopeful that they are capable of doing this. The commitment that they've made, again, the desire, the commitment that they're bringing to the table is huge. That if they've set an intention, we want to support that intention regardless of the behaviors that are coming through. And then helping them to trust themselves in their decision-making ability and supporting that autonomy. That, like I said, they can make very small steps in the right direction, and each one of those is a success. And if we're not highlighting that, then we might not be as effective as we could be for folks that are at this phase. Once somebody reaches action, our role is really to help them maintain that confidence and to write out any issues that they might have if they set themselves up in a way where they take on too big of a goal, or they're maybe not successful or as successful as they'd like. We don't want people to get demoralized and start to go backwards. That any attempt to change, we want to be reinforcing in the action phase. So our goal is to help at the onset when they've set up the plan to decrease any barriers and sort of see those roadblocks and help them problem solve before they start to experience them. We want to encourage any progress, look at what can we get out of the way, what can they begin to get out of the way so that they're as successful as possible, and help them to restrain biting off too big of a chunk. So a lot of folks, especially if you've done a really good job in contemplation, they're really excited about moving into the action phase and acting on their plan. They might decide to take on too big of a goal or too many goals at the same time, and that's really setting them up to not be successful. And so having a really frank conversation with how they can kind of pare that down so that it is achievable and realistic compared to all of the other things that are going on in their life. So we talked a little bit about relapse and how it is part of the stages of change, and understanding that this is also important to have a conversation with your patients to help them see that relapse is a common occurrence in recovery. This is a normal part of the process. It is not in and of itself a sign of failure. We do not want people to end up having what's called the abstinence violation effect, which is a psychological phenomena that occurs when somebody isn't successful at what they've set up for themselves, and so they just say, screw it, and they throw their whole plan out the window. So we want to be talking about relapse or slips before it happens so it doesn't have that kind of effect on them. Normalizing this is part of the process of change, whether that's diet change or exercise or sleep schedules or medication adherence. All of those things are going to have a component where you might slip back into your old established behaviors. And that's called habit, right? And that's a really hard thing to overcome and to change a habit. So we want to educate them that what they're working on is managing a chronic illness. And so there are going to be triggers that are going to come along in their life that are going to place them at risk. And if they have a slip, that doesn't mean give up on the plan. That doesn't mean they fail. That doesn't mean that they throw everything out the window. It just means we need to look at that as a learning opportunity. So our goals during when a slip or a relapse does occur at any point in this process is to help them avoid becoming discouraged, help them avoid the abstinence violation, and help them re-engage in that change process. And if that means going back to do some more MI, some more work like in contemplation, really boosting the part of them that wants to make that change and get back on the horse, or if that means just taking them back to action and reviewing their plan maybe something went wrong, or maybe something wasn't as tight as it could be, helping them to really look at it objectively and with a solution focus. That's our goal. So that's the stages of change component. Now let's move into MI. Let's talk about what you need to know about specifically the spirit of MI, not necessarily some of the technique components. Now, I think this is an interesting graph to look at, because what this says to me, this is talking about the amount of money that countries spend every year, the dollars that they spend on health and medical care in the service of having longer lifespans. And you can see that we're on this interesting curve where we spend a lot of money in these areas, but that doesn't necessarily result in having a longer lifespan or being a healthier population. So what that means is there's something not quite right in how we're talking with folks about any kind of health behaviors. So this was a quote from 1660 that sort of highlights, we've known for a long time that people are generally better persuaded by reasons which they themselves discover than by those which have come to the mind of others. So when folks are talking about change or wanting to make significant changes, whatever those might be, when it's their reasons, when they're the one that's making the rationale and the persuasive argument, they are going to be so much more successful than when we're the ones making the argument. So this is why MI is different. It really isn't a therapy as much as it is a way of talking with and being with people in the process of making changes, whatever those might be. It is an approach that is highly collaborative, person-centered, and is focused on guiding someone by eliciting their own reasons, their own values, their own motivation for making that change, and highlighting those reasons rather than getting them to do something through a specific technique that we might be applying. It's also something that will help people make changes not just in their substance use, but in all kinds of other behaviors, lifestyle change behaviors, but only when there is some sort of reluctance or ambivalence going on. Why is this a different approach? Part of it is because it's tapping into a person's own commitment to change, their own rationale and reason. So we're helping them to think about and interact with us around change slightly differently. So if you think about MI, it's not really a collection of techniques, sort of like CBT or some of the other approaches that we might have, but it is a way of being with patients. It is a way of relating to patients that is very focused on highlighting their reasons to make a change. So it works with people instead of at or for people. It is very much encouraged to be present focused. So thinking even from a harm reduction perspective, what can you do? What are you willing to do right now to be a little bit healthier or to move in the direction of what you just told me is important to you? So it's not about what you're going to do next year. It's about what you're going to do right now today. And it has applications across a wide spectrum, not just within the field of substance use. It is highly evidence-based. You're going to get these slides, so I'm not going to go through all this stuff, but essentially there have been tremendous amount of research studies done on MI, and they have shown that when utilized at the right point in treatment, so people that are in that contemplation stage of change, it is highly, highly effective at helping people make significant adjustments to lifestyle, to use behaviors, to any number of things. Weight loss, medication management. So rather than digging into some of the techniques associated with MI, if this sounds like a way of being with patients that you would like to learn, I would highly encourage you to seek out additional training in motivational interviewing, because this is a very different style than how the traditional medical model trains us to interact with folks, where we're sort of the expert and we tell people what they need to do or should do. MI is a very different way of being with people. you really do need to get training on this and maintain training. This isn't something that if you went to an MI workshop 10 years ago, if you're not actively consulting or practicing this, you probably have lost a fair percentage of what you learned. Because this is such a different way of interacting with patients, I very much encourage you to consider getting training on this or joining a consultation group in your community or starting one in your community where you can actively be practicing how to talk to patients using MI. That being said, what we're going to spend the rest of this time talking about is the stuff that you can use without training, and that's the spirit of MI. So what is that? So that is really walking into the room with someone, being able to identify sort of where they're at, and when that ambivalence shows up, appreciating it, because that is an opportunity. So what is ambivalence? Well, really it means of two minds. So feeling two ways about something or being on the fence about something. And I think all of us can relate to that, that if we've ever identified, you know, this is something that I've been doing and it's causing me some issues, but I really get this out of it. Now I've of two minds. I have positives about it and some negatives about it. It doesn't mean that the person lacks motivation. It just means that they have these conflicting viewpoints, right? That there's some discordance there. And this is a natural part of change for all human beings. It's a normal response. So before we can make a significant change in a habit, we have to have that ambivalence there. As providers, we can have a tendency to get caught in what's called the communication trap. And so that's where we clearly see the negatives. We think that if I just highlight the negatives more, if I just help them to understand this better, so arguing essentially one side of those two sides, what am I going to do? I'm going to put them in a position to defend it. So that's something I want to actively be avoiding. I want to appreciate that ambivalence is an opportunity for me to have a different kind of conversation with folks. And so rather than getting into an argument where they now have to defend the status quo, they need to start to tell me why they shouldn't change. I want to have a different kind of conversation, because the second I start getting into that yes, but conversation, they are going to be much less likely to move into action and to start to make changes. So this is called the righting reflex. So if I'm adopting the spirit of MI, I need to understand, as a provider, I'm in this field because I care about people. I want them to be as healthy as they can be. I want to help them make positive changes. I want to sort of right the wrongs that are going on in their life. So this is a natural inclination that we all have to try to make it better for the person sitting in front of us. Why this is dangerous and why we need to try to work against this by adopting the spirit of MI is because when we tell other people what to do or how to do it or why they should do it, without talking with them using this person-centered approach, they're not going to learn from it. They're just going to go immediately into defending it. So we want to think differently about how we can avoid telling them that how to or why it should be different. We don't want to create resistance and a defense of what they're currently doing. We want to help them to explore that in a way that they really see another option and they see a solution that is personal to them and that comes from them. So why do we think this happens all the time? I think one is, we really care about the work that we do and we want to help patients live better lives. One thing that we learn is part of our schooling or experiences, and that I think is totally natural in coming to believe is that, patients really, they don't see exactly what they're doing and why it's not helpful to them. Maybe they don't know what's going on or what's wrong, or they don't know how to make specific changes. And sometimes, depending on the patient and the kind of problematic behaviors they might be bringing to the clinic, we might begin to believe that they just don't care. And some of that goes back to being, having very limited options, having a lot of adverse childhood experiences, having negative experiences with healthcare and healthcare providers. They might come highly defended to an encounter, and we could take away from that, they just don't care about changing. So when we're coming to the table with those kind of ideas, then we are going to be much more inclined to give in to that righting reflex, to try to say, you know, I'm going to work to give them insight. I'm going to work to give them knowledge. So they need information, they need, or they need skills, that this is a major skills deficit. And in the place of action, once we've moved into the action phase or the planning phase in the stages of change, some of that might be true, that they actually do need some knowledge or some skills to enact their plan and be successful. But in terms of contemplation, getting somebody willing and ready to make significant changes, that's typically not the case. So we are in error by thinking they just don't see it, they just don't know how or what to change, and they just don't care. So that's, I think, one of the reasons why we fall into that trap. And unfortunately, because ambivalence is a normal part of the change process, when it's on the table and we come at it with the righting reflex, we come at it to try to get them to do something different, what do we think happens? Well, it's not, it ends up becoming a tug of war, or it ends up becoming an argument that isn't probably going to benefit the patient very much. We end up putting them in a situation where maybe they make a change briefly to sort of satisfy us. Maybe we have enough rapport where they want to be the good patient and tell us what we want to hear, but that's not necessarily going to be continuous or sustained change. Maybe they listen politely, but then they just proceed to do whatever they're going to do anyways. Maybe they push harder. Maybe they argue harder or protest even more, and we get into an even more activated argument. But at the end of the day, nobody benefits. We don't feel good about it. They don't feel good about it. And typically, they end up blaming themselves, and we end up blaming them and saying, they're just not ready. They're just not motivated. But what's happened is we've hit that ambivalence with the righting reflex. So in terms of adopting the MI spirit, it's helpful to keep in mind this rule, which means, number one, be prepared that the righting reflex is going to show up and be active in resisting it. Number two, understand what your patient's motivations are. So if you haven't had a really thorough conversation about their why for change, then you probably don't understand what's going to be core to helping them in making some of those changes. So really seeking to understand what their values are, what their motivations are. Have you listened to them sufficiently? Do you really think that you understand what they're coming to the table with and what their why is? And have you thought about ways to empower them rather than doing for them, rather than trying to persuade them? Have you thought about ways that you can empower them to support their autonomy, empower them to make the best choice that they can, even if it's not the choice you think they should make in that moment, but they're the ones that are making it with the information that they have. So it's going to be more meaningful. So if we think about the spirit of MI, it really is the foundation that we can add the principles, the processes, and then the techniques on top of. So if we have that foundation, we're probably going to be fairly effective at any of the interactions that we have with folks, especially those that are coming to the table with that ambivalence. Another acronym that goes with MI and the spirit is ACE, and that stands for acceptance, collaboration, and evocation. So let's walk through what that means, because I think that these three components can be applied to pretty much any setting and whatever your role might be with folks. So acceptance, that means that when we're talking with someone, we are accepting them and giving them a sense of absolute worth. So having positive regard without judgment, and having respect and trust. So recognizing no matter what state they're in, that they have absolute worth. It cannot be created, it cannot be destroyed. When people experience this type of acceptance, then they feel free to change. It's kind of an amazing thing that if they feel unaccepted or judged or criticized, they are more likely to dig their heels in, versus when you say, hey, you're here, that's awesome. Let's talk about, what's important to you, rather than us coming to the table with some of that judgment. Now, all of a sudden, they're free to explore options that maybe they weren't free to explore before. Acceptance also means bringing to the table accurate empathy. So working really hard to understand what their perspective is, what meaning their potential change has for them, and the values that they're bringing to the table. What is their why? And then giving them autonomy support. So acknowledging that they have the freedom and the capability to make choices, that they have certain attitudes and behaviors that have probably kept them alive up to this point, and we want to honor that. So we want to really reinforce that autonomy, that even while using, that even while engaging in some high-risk behaviors, people can and will make good decisions. And so we want to be supporting their ability to do that. And then how we approach that is by offering up affirmations, actively communicating appreciation and awareness of their strengths and any effort. So any effort, including showing up in the office that day, is something that can and should be affirmed, rather than us having some long-term goal in mind and waiting to affirm it when they get there, affirming all of those little steps along the way. So essentially moving toward autonomy, so that means affirming their rights and capacity for self-direction and making informed, healthy decisions, honoring them regardless of their use, accepting that this is who they are at this moment in time, and having optimism that they can do something to make changes if they wish. That's versus the standard medical approach, which is where we as the provider tell them what they should or need to do, and assuming that people need to be told or instructed because they won't make healthy decisions when left on their own. Collaboration, what is this? So this is the C. So that means that rather than it being a top-down approach, or the provider is up here and the individual is down here, that we're going to view them as an equal collaborator, so that we're both experts in the room. I have knowledge and you have knowledge, and we're going to come together and figure out the best way to work with that. So if you think about that, instead of wrestling where one person wins and one person loses, it's more a dance. It's more interacting, sort of a back and forth, give and take that creates something really beautiful in the moment. And so it's more about exploring than persuading. That's really interesting. I'm really curious about that. Tell me more about that. That type of language communicates collaboration. Because remember that MI is done with the person, not for them. This is really where patients get to be undisputed experts on themselves, where they get to talk about why and how they're going to do it, rather than it coming from us. So when we're adopting the spirit of collaboration, we're developing a partnership that honors their expertise and their perspective, versus the typical medical model, which would be where, we are required to sort of impart our knowledge, our expertise, our reality onto what is best for them. And lastly, evocation. So what does this mean? This is where we understand and really truly believe that patients come to the table with everything that they need to make the changes that they want. So understanding that they bring it forth. We might be part of eliciting it, but it's already there. So it's recognizing they have some of those internal resources. So we don't have to wait until they're ready, that we can capitalize on that. We can evoke the part of them that wants to make those changes without having to wait for it to be evoked on its own. So this really strengthens their why that has been communicated. So if we don't understand the why, we don't understand their perspective, we can't evoke. So it's another reason why it's really important to have those conversations. When we're evoking, we're enhancing that intrinsic motivation. Why do they want to make these changes? What are their perceptions, goals, and values that they're bringing to the table that we can capitalize on? Versus saying we need to provide them education, we need to provide them knowledge, and then they'll change. So you can see how that's a different perspective by evoking what's already there, different than I have to impart something that isn't there. So again, think about it not so much as wrestling, which is the traditional medical model where we're trying to get people to make the changes that we know as the experts would benefit them. We're really moving more in the direction of dancing with our patients, recognizing this is collaborative, that they have a whole host of strengths and skills that they already come into the room with, and all we're responsible to do is explore that and evoke it and affirm it and help them move in the direction of the change that they already want to move in. So that is the lecture. I'm going to open it up now for any questions or comments.